Thank you so much, Kim, for that very valuable information. We are going to start the panel discussion now, and I'm only going to lead the panel. We have talked at you for over 2 hours now, and so I'm going to introduce another panelist member. He does not have a separate speaking part, but that doesn't mean he's any less important. It's the gentleman way on the far left, and his name is John Wilton. John, nice to see you. John has almost 20 years of experience in the Ohio workers' compensation system, including an extensive history spent working with a third-party administrator. John's extensive background provides him with an understanding of employer issues and challenges faced by BWC customers, and with this perspective, John can customize solutions and tailor them for each specific situation. I've worked with John in an important Geauga County project through Working Partners and a huge survey that was funded by OMAS last year. John has exceptional experience and advice to offer. And John, why don't we start with you? And so you can tell our audience first about the drug-free safety program that the Bureau of Workers' Compensation has, its utilization rate, and what's being done to increase that rate.
Hello. Yeah, right now the timing on this is pretty good because the deadline to enroll in the drug-free safety program through the BWC is at the end of the month. And kind of go over it, relatively briefly here. There's two programs. There's the basic level and there's an advanced level. Basic level, an employer will get a 4% rebate on their premium, so it's not an upfront discount on your premium. It's a rebate. So you got to complete the program in order to qualify for the rebate. In a nutshell, it's pre-employment, post-accident testing, employee and employer education as well as part of the process. It's a pretty simple program to utilize, and obviously, you have to use a qualified vendor in order to do this. So it's not something where I can just pick a supervisor to do some training on this. You want to work with a vendor in order to create those policies. Now, there's obviously more involved in there in terms of actually creating a policy, and safety initiatives are built into that program as well. Now, the advanced level, you can get a 7% rebate for that. With that, same type of pre-employment, post-accident, employer education, supervisor training as well, education. Now, there is a 15% random testing requirement with that program, and that's anybody in the company. So it's president all the way down. Everybody gets to play ball. The other thing, too, is I would say with the advanced level, we do ask an employer to commit to second chances. So that's something taken into consideration. When I talk to employers, I recommend them to talk to the vendors that they want to work with, and we can provide a list of vendors and talk to them about what program would fit their program, their company the best. On what I've done over the years, one of the things I'd like to touch on too, real quick, is I'm a big proponent of prevention in the first place. I don't know, employers here, anybody here use our safety services, safety consultants? Okay, I have one person. Okay, the safety consultants, the whole part of this is preventing the injury in the first place. On our, when we're looking at workers' compensation, the safety consultants, they're no cost. They'll come out and do the walkthroughs. I mean, we could, I was kind of looking through here, and you look at the trip hazards that you have here. You may have them at your office. And those, we've heard the stories of I trip, I fall, I break my arm, and then all this stuff starts. So have a safety consultant come in, have an ergonomic consultant come in. You have one thing I hope you see today is you have a ton of resources available to you. In terms of some numbers, quite honestly, I would say this, in terms of the drug-free safety program overall in the state, We have 6,600 employers participating in the drug-free safety program. So now, obviously, most of those employers do have some sort of program, but through our program, there's 6,600 employers. Some statistics we've seen from employers that were involved in our drug-free safety program, their injuries would drop from an average of about 5 injuries a year over a 3-year time frame down to a little less than 4.5. And then their EMR rates were about at 1.02, dropped down to 0.98, which in that world, our premiums dropped. We had less injuries. We have less exposure. So that's really what all I needed to touch on was.
John,
Deadline's coming. Well, I'm sorry. It's my world. Experience modifier rate. That's what your premiums are based on, this rate. So 1.0 is a baseline. So it's like golf. If you're in the plus 1.02, that means your premiums are higher. If you're below 1.0 at 0.98, your premiums are less. So that's obviously important to employers as well. But
so when you say 6,600 employers are availing themselves of this program, what is that percentage of the total of what could avail themselves of the program?
Well, let me just. If I look at employers that qualify for the rebate, so this would be group-rated employers or experience-rated employers, we have about 86,000 employers that are in group rating or that are just in group rating. You take experience rated, they're not part of anything, your numbers are going to be well in the 100,000. We only have 6,600 that are participating. In Lake County, I took a number and wrote down 2,300 employers in Lake County would qualify to participate in the drug-free safety program. 40 employers participate. 40. Now, that doesn't mean that everybody else out there does not have one, but when we have a structured plan, but if we don't have these kind of structured plans, we may miss out on our employer training, or we may miss this part because we're not, it's our policy, but if we did it this year, we missed it this year, so there's much room for growth.
Right, and how could the folks here help you in growing that?
Well, I'd say the biggest myth I would say I've seen over the years is employers tend to too much look at the rebate. They just say, well, I only pay premiums of $1,000 a year. Just make it simple. I only get 4% back of that. Why would I do that? It's not about, to me, it's not about the rebate. The rebate is to help to offset vendor costs and just to implement, give somebody a reason to do it. I think everything you see up here is the reason why we do it. I mean, even if I didn't get anything back, if I could keep my EMR rates low, if I could keep my employees educated. I mean, half the stuff was talked about today, it was it was very useful information, But if we don't we tend to look too much at the rebates. My suggestion would be get past the rebates, worry about keeping my employees safe, keeping them healthy, helping their families from preventing these injuries in the first place, and then talk to those other employers about, hey, this program's available. It's a structured program. We've been doing this for years, so I would say that'd be the best way to try and get those numbers up.
Great, thank you, John. And we've heard this consistently is all about prevention. And so from a prevention perspective, I'm going to ask the panelists to weigh in. A healthcare cost of prescription meds for your employees. Is there a way legally to take a look at the healthcare costs of your particular company and to identify those employees that are using and that may have a problem to do some kind of prevention efforts before it gets to be a full-blown addiction? Is that a possibility? And does that happen? Karen?
I do think that employers they really need to be careful about what they know and what they're going after, but they can partner with people like their managed care organization or their third-party administrator of workers' compensation or their insurance providers to take a look at some of these things. But really, if you're doing best practice drug-free workplace, you're doing education for everyone, you're doing supervisor training for all supervisors, but there are ways, I think, to partner with some entities to address some of those issues, Randy, that you're speaking.
So what would be those entities if STERIS wants to take a look at that? What would you advise, and how would they do that? What does that look like?
I think they can start with reaching out to BWC. They're, like I said, they're a managed care organization. Everyone's got a managed care organization through because of their participation in workers' comp. Their third-party administrator, if they're group rated in a workers' comp group, their insurance plan providers, their medical insurance plan providers, those type of partners.
Grant, from a legal perspective, an attorney in this.
Right. So one thing that I would caution against is you really can't go out and ask your employees what prescription drugs are you on because you're going to be in violation of the ADA. That gets a little bit more complicated as you start asking questions about a person's disability or the effects that their prescription drugs are having on them that could cause a disability under the ADA. That it's a pretty dicey situation that you're entering into. What you can do is look at how people are performing under their job, whether or not they're being productive employees, and if those issues arise, you can start asking questions about why you're not being productive or meeting certain requirements. But when you start asking about their specific health conditions, you need to be very careful about that.
Kim, what has been your experience with businesses? How long did it take you to start to break the barriers between Adams Board Social Services and the business community first? And then a follow-up would be, what kind of social services are available to businesses in Lake County?
You know, I think it actually happened so quickly, which for us in the social service world is pretty unusual. We're used to processing things. But when we reached out to Leadership Lake County and asked them to start helping us open doors, it was literally 3 weeks later we were out doing our first presentation. And then what has happened is it has spread through word of mouth. I have gone into a number of employers who have said, you know, I had to twist my boss's arm to let you come in. He doesn't buy into this. She doesn't think this is worth it. And then as I walk out the door, they're saying, can you come back and talk to our other shifts? Or we need to let you, 3 other manufacturing companies know about this. And part of the reason for that is any employee who is struggling, whether they're struggling with their own addiction or taking care of a grandkid or worried about their son at home stealing from them while they're at work, they think they're the only one. I promise you, they think that they're the only one, and they're not inclined to go to their boss and say, I'm not performing well, and here's why. When we come in and we talk about this, and we talk about how we got here as a country, what has led to this, and we lift the stigma, folks are more willing to reach out. And again, they can then access help and support through their employer, or they can call the Compass line and say, you know, I don't even want to tell anybody that my grandson is struggling, but how can I get some anonymous help? And we will help them navigate the system and find out where they can get free services, where they can go to anonymous support groups, all of those kinds of things. So that's what we have observed.
Thank you. Dr. Jurnaczyk, I've got a couple questions for you. When you've done work in China, and I know another local Lake County attorney, Skip Sweeney, does some lawsuits with regards to the wrongful death of overprescribing of physicians, as it being a statutory duty of care. And when he goes and takes depositions of doctors of other countries are absolutely shocked by our prescribing practices here and our absolute reliance on the prescription pills for treating pain. So why do you think in this country we have that, number one? And a follow-up would be, do you see alternative treatments while organizations, hospitals are doing some alternative treatments. Where do you see that, and where do you see that as a place going forward in treating chronic pain or acute pain?
Yeah, so thank you for the questions. A couple answers to that. I mean, it is complex, right? I mean, somebody challenged me the other day and said, right, we use 80% of the world's opioids, 5% of the population. We got to do something about this, and this isn't a problem in other countries. And I said that might be true, but I'll tell you, I didn't see pain control. I saw people suffering in other countries too. And so pain control and managing those patients, remember, we have to address that, is not always really optimal in some of those countries. And it's finding the right balancing act, I think, somewhere. I can tell you, I could only write for 7 days of an opioid in China at a time. And the rules and regulations were really tightened on me. But it was also, there was perceptions, right? I'd said earlier that, I'm going to treat you, but I'm not going to make your pain zero. I very rarely had patients who expected that when I was in China. I used to do work down in South America a little bit, pulling people's teeth. People just said, I'll take a Tylenol and that's it, thank you. Right? So I think some of it we all share in this, right? Our nursing staff, the fifth vital sign, we talk about this all the time at the hospital on the floors. It's really easy to say, are you in pain? May I get you a pain pill? As opposed to, can I reposition you? Can I help you? We do music therapy on our floors at Ahuja. Can I get the music therapist to come up and help and talk to you? Which leads into the question about the alternative. It is cheaper, easier, much quicker for me to write you a prescription for 90 Percocets than it is for me to get you in to see an acupuncturist, therapist, something like that, right? Insurance companies don't often pay for it. There's an access issue. There's not always there. But I sure can write with my pen today, right now, 90 Percocets, and you can go to CVS and get it paid for very quickly. So I think there's a little bit of that is going on in our society. It's the expectations. It's the ease to be able to get it. And we're in a society where we want to do something. I want to help you, right? If I can get you something in your hands to help you right now that's going to get paid for, I'm going to try to do it. So those are starting to shift. We were talking to our folks at our Connor Integrative Medicine just the other night. I was meeting with them again, and they were really working on policy and advocacy to start to shift this so more insurance companies will pay for and we can get better access to acupuncture. We're looking at seeing if we can get an acupuncturist on our surgical floors at Ahuja, for example. Regardless of the cost, how do we make it work economically, because that is an added factor to it. So I see the tide starting to shift in those areas. It's not a tide that's going to shift very quickly, but I think we all have a part in that, what our expectations are, what our healthcare benefits will support and cover, how we as providers help advocate that and kind of share that message and start to direct that way. But it's a complex situation that we need to really do to shift that tide to get us to similar to what other countries are. But again, with the caveat of we have to make sure that we're also treating people's pain. I saw people suffering in those countries without an opportunity to go get treated. That's unacceptable also. So we have to find that right balance.
Thank you. I'd like you to speak to the issue of nutrition and the American diet as it relates to possibly priming the pump of the brain for brain addiction, the disease of addiction, as sugar hitting the same receptors in the brain as heroin. And for Kim Leininger, the stated that we have the food pantry issues, number one, in Lake County and in Geauga. And so what is the health of the food supply, and how does that feed into, if it does, the disease of brain addiction?
Great question. I'll say I'm not an addiction specialist, so I struggle a little bit in that area, but they are so related, right? The centers of the brain, and how do you, it's that, kind of the pain centers and the gratification centers in the brain, they're all really well linked together. And so feeding might not be the right term when we're talking about food, but right, the kind of the stimuli that go into those centers of the brain are so interconnected. And so if people can't get food, if people are struggling for their daily basics and to get that the needs that they have, the satisfaction of getting a meal when they couldn't get one, and if we're able to really, and maybe not just a meal for yourself, but the centers of the brain for, can I care for my children and feed my children, right? Which, I don't know about you, but most of us have never lived in that situation. to have those parts of the brain and that part satisfied is really a key driver, and a lot of it's centered in the very basic parts of the brain, so they're very well connected. I won't lie to you and totally understand the true pathology of that, but there's really a lot of link there. Maybe somebody else on the panel has a better idea of the pathology or the psychiatry of that, but there's a clear link.
So if we talk about the brain disease that it is, that on the other end of that stick is the stigma. So we've heard the word stigma. So I'll open it up to all the panelists to address stigma. For this panel, we've all been doing this for a number of years now. And so if you're kind of new to this, and maybe some members in the audience or those watching, can we address stigma, what it is, what the stigma is, and how that has hurt treatment, how it's hurt our employable population, and how it's hurt families. Kim?
Sure, I'll jump in. I will tell you that, unfortunately, as in the United States, our past 50 years has really been the picture of how not to deal with the disease of addiction. And opiates have been around forever. The founding father of modern medicine called opiates God's great remedy. They've been around forever, and they've been abused for a very long time. But this issue of whether or not we are treating someone with an addiction or we are punishing somebody who's an addict, that's been our challenge. When we had, going even back to Nixon declared war on drugs. Really what he did was he declared war on drug addicts. And it was sort of the presidential seal on stigma, because it became the big us versus them, and we who weren't addicted were able to look down on those who were addicted. And we sort of have perpetuated this through the years. The next decade we had Just Say No, well-intended, but probably the three most damaging words when it comes to addiction, because what does it imply? It implies it's a choice, that if I choose to say no, I won't have addiction. That didn't work, and we moved into the next decade where we said, if we just lock up everybody with addiction, we'll solve our problems. We went from 40,000 nonviolent drug offenders incarcerated in the mid-'80s to 200,000 in the mid-'90s. So we locked up everybody. We just continued as a nation to say we don't know how to treat these individuals, so we're going to shame them, we're going to put them down, we're going to put them away. And it hasn't been until recently, frankly, when this started impacting all of us, my niece, my cousin, your brother, your aunt, that we started to lift the veil on stigma. Unfortunately, what we're starting to see now is that there is this burnout, right? This compassion fatigue that we're all feeling. It was really easy to say, wow, I feel for my niece, and I want to try and get her help. And then I tried again, and then I tried again, and then I tried again. And if it didn't work, it's become easier for us to burn out and to say, nothing's going to work. And so unfortunately, we're seeing a little bit of stigma rising. I think collectively, part of our job as employers, as family members, is to really push back on that and continue to recognize that this is a disease like any other major illness, and that it's treatable.
I just want to add, Melanie Blasco is here from Lake Geauga Recovery Centers, and they're doing something really great with their alumni group, and they're getting a great response. People who are in recovery continue to come together even after treatment is over, but they're out there in the community and they're willing to let people know, look, see my face, this is a face of recovery, and it's okay, and there are resources out there. So I too think as groups like that grow stronger and are more vocal in the community, and it really brings it back to, yes, it is my neighbor and my friend and brother, sister, employee, whatever, and whomever, but it really connects it back to our communities. So
Thank you, Kim. We'll open it up for questions. We have two mics. One for Angela will take one side of the room, and Kathy will take another. So can ask questions of the panel.
Are they gonna do any exemptions for surgery patients to a point? Because that's when you need it the most.
Yeah, no, I agree, and it's interesting because this goes back to one of the issues of some of the overprescribing. A friend of mine said that they had their teeth removed, a couple teeth removed. Their dentist gave them a whole bunch of them, right? And she kind of pushed back and said, "Do I need these?" Right? I forget what it was. It was like 30 something pills, and he said, frankly, you probably won't. But I can't call it in anymore. I used to be able to call it in, right? I can't. My office is closed over the weekends, and I want to be able to help you. And so I'm going to make sure you have enough to get you through the weekend. Just on that case, you do, right? And so there are legitimate reasons why people do that, because there are some restraints, and nobody wants you to waking up at 2 o'clock in the morning and can't help you for the surgery. As far as what the restraints are on the medication, so there are becoming more and more restraints as to how many pills I can write for, similar to like what I said was in place when I was in China across the board. I think it is going to continue to ratchet down and what there is. And that might be good, but what I've said through our Pain Institute and the work that we're doing, we're starting to challenge our specialists in the different areas. So look, I'm not a spine surgeon, right? So let's get our spine surgeons to the table and let's understand what a typical person needs, kind of what the course is, and what we should be doing to send people home with. And now let's all get online with that. And so we're really trying to challenge our specialties within, because frankly, I'll be honest with you, sometimes it is, there's not a lot of standards. What is the right amount after a spine surgery? What is the right amount after a kidney procedure, for example? You look in the literature, it's not out there. So let us start to define and develop our own standards based on what we recognize. And I think that's a simple way we can start to do that and bring our specialists together. So that's one of the areas that we're working on at UH, and I know several other places are doing the same. I want to be able to do it before the law tells us we have to, because that means we're taking control of the situation and helping. Yeah. Thank you.
Question here. Is that population demographic? Is it our industries? Is it the prescribing practices of our physicians? But what is it unique to the Great Lakes region and specifically to Ohio that makes us the epicenter?
Yeah, so, and please anybody else chip in if you want. I think that book I showed you at the end, again, I'm not getting royalties, it did a great job at really kind of pulling that together for me as to what happened. I'll speak a little bit more for Ohio because the story was there. It was really this fascinating confluence of issues that occurred with the OxyContin was named a lot and how it was marketed quite a bit in the several state area. And interesting, the heroin trade, how that really started hitting, and it was an open market. And they talk a lot about in their nice drug dealers. Who's ever heard of something like that, right? But these guys thought of themselves as being able to just be like your pizza delivery guy. You call me up and I'll be delivering your heroin to where you are with a smile. And that kind of happened right at about the same time in Ohio, at least, that a lot of the the OxyContin prescriptions were up there, were real true pill mills that were going on, and all these things really started to come together. Now, of course, I think that's a simplification of it. There's probably a lot more as far as the social determinants of what's happened with, unemployment at the times that were happening, things I'm not really a specialist, but I think that made all those things set up Ohio to really be the firestorm for a lot of those issues. Yeah, it's a fascinating read.
Yeah, I think
Yeah.
another really big piece is that in Ohio, we have this tremendous interstate system.
That's
You
correct.
go to any other state and you can't get north, south, east, west the way you can. There's a road that comes up out of Mexico through Texas right into southern Ohio.
That's right.
And then we have access out of Canada through Detroit into Toledo. Getting drugs into the state is easy, and then once they're in here, getting them north, south, east, west is tremendously easy.
That's exactly right, and that's where
Yeah.
this delivery system, right? The pizza delivery guys can only do it if they could get access to the drugs, and so you're absolutely right. I think we are geographically at a really interesting place, and then all those other things that came together.
Right, that's human trafficking is a huge issue in Ohio because of that as well. And our organized crime folks from the Attorney General's office went down to El Paso, Texas to work with the border agents there. And there's a direct line from El Paso, Texas, a bus line to Dayton, Ohio. And so they come across the border. The Mexican drug cartels have infiltrated Ohio and very easily and very quickly. And so what had happened, again, it's a long story, make it short, but Dr. David Proctor, a Canadian doctor, came and with the marketing of OxyContin by Purdue Pharma in 1996. Set up pill mill shops in southern Ohio, southeastern Ohio, and gave rise to a huge addicted population. When the legislature went after the pill mills with the Attorney General's assistance, those were shut down, and you had an addicted population, and the drug cartels are great businessmen, and they put up business models to get those. I don't understand it either. I guess I'm not being very clear. But the book is good, and I mean that's a simplification, but that can give you an outline. I hope Siri understands that as well. So.
I'm wondering, is there a tie between our everyday use of painkillers and then what they have to prescribe when we have terrible situations like surgeries?
That's a great question. I hadn't really thought about like that before. A couple things to your first question about the regular strength versus the extra strength. When you look at them, we dose oftentimes these items on a milligrams per your kilogram, so your weight. And so a lot of those, like 200 milligrams of ibuprofen, is really kind of almost close to like 10-year-old. I mean, my 8-10-year-old children would be taking that. So if you think about it, extra strength really does tend to be more of an adult strength, but that's how it was originally taken off of prescription at those lower strengths. So I don't think that has anything to play with that. But that's an interesting perspective I hadn't recognized. As far as the tolerance, it is true. So I mentioned in my presentation the tolerance level, whether using an opioid for chronic pain or for recreational use or anything in the middle, right? You do start to develop more and more of a tolerance. So if you come in on, I don't know, make it up, 2 OxyContins a day chronically, and now I'm doing your surgery, 2 OxyContins a day are not going to help you, right? Whereas if you are what we call opioid naive and not needing it, 2 OxyContins a day might help you post the same surgery. So there is a complication there, but there's not a cross tolerance, if you will, from like ibuprofen and Tylenol to the opioid. So if you take 2 Tylenols a day, that doesn't mean you're going to need a whole lot more OxyContin. Does that make sense? To try to tie those together. Yeah, that's a great insight. I hadn't thought about that. No, it's true, but there's not that cross tolerance to that. Thank you.
Karen, a question for you on the drug-free workplace programs. How many drugs should employers be testing for? I know that's an often asked question. There's different categories and certainly different costs associated to it. So what's the recommended practice? What's certainly the best practice? What does that look like?
I think it's really important. A lot of people talk about 5-panel, 9-panel, 7-panel, 12-panel, 15-panel. The problem with that is you can't just say a 9-panel is the way to go, because the drug testing vendors call them different things. So it's really important that you get your vendor to supply your drug testing list in writing so you know what you're testing for. For example, in the old days when you did a 5-panel test, I think I showed you, one of the drugs was opiates. And if we really are being very particular, the difference between an opiate and an opioid is that an opiate is organic, which meant if you were testing for opiates, you were only testing for heroin, codeine, and morphine, not the semi-synthetics or the synthetics like hydrocodone, hydromorphine, etc. So first thing is, before you start worrying about the numbers, try to figure out what you're already testing for. Some drug testing vendors, it will still say opiate, but they'll tuck the hydros underneath there. So you don't even know for sure that you're testing for the hydrocodones or the oxycodones. I would say a really good place to start is to take a look at what the Department of Transportation requires truck drivers be tested for. And if you're in the drug-free safety program, they mirror that list. So it basically is the 5 that I mentioned, plus those expanded opiates. That would be a place to start. I just want to encourage you not to get caught up in the 5, 7, 9, 12, because they're not the same thing for vendors. So get your vendor, get your list, take a look at it, ask them exactly what they mean by opiates so that you know whether or not you're testing. For sure, these days, OxyContin, oxymorphone, hydrocodone, hydromorphone. I don't have a lot of employers that are testing for the pure synthetics like fentanyl, But just start by knowing what you're testing for, and at least at minimum mirror what DOT or what the drug-free safety program recommend or requires.
Karen, that begs the question then, I'm an employer, how can I be certain I'm not interfering with an employee's appropriate use of pain medication?
That is really important, and that is to do gold shelf drug testing, best practice drug testing, which is a system where the person goes and gives their donation at the collection facility. It's shipped to a federally certified laboratory where they do a screen test. If something shows in the screen test, they do a different science to do a confirmation test against cutoff levels. So if a certain amount is shown in the system at the confirmation test, here's the best practice part with prescription medications. The result goes to a doctor, to a medical review officer who really is the advocate for the employee, not you, the employer, the advocate for the employee. The medical review officer, without the employer knowing about it, calls the donor and says, do you have a medical reason why this is in their system? So if they have a legitimate prescription that belongs to them and is not outdated, the medical review officer will call that test a negative. So the employer doesn't know, oh, it was kind of positive or they're taking Valium. It is sent to him as a negative test. That way the rights of the employee are protected against the legitimate use of medication. So that testing without a medical review officer is scary territory because of that.
And I'll also add, really, I think this is a very, I mean, from the employment side and from the clinical medical side, this is very confusing and it's very challenging. I think when you add into the issues of, right, so some drugs stay in your system longer than others, it depends on the utilization, and so, right, you know, I saw somebody that looked like they were intoxicated last Friday, and I'm going to drug screen them today. It may or may not be helpful. Those are a variety of other issues that really make this a complex issue, but there are good guidelines to help you get, you know, to get you in the right direction, but it is very complicated. That was a great kind of overview.
So is there any way that you can put in your employee handbook that people can return to work once they are drug-free from those type of drugs?
Yeah, that's something that you can include in your employee handbook, but you need to be sure that if you're going to put it in your handbook, you need to follow it consistently and in a non-discriminatory way. So it needs to be applied to all of your employees the same way. And again, that also borders on what that direct threat exception to the ADA. So if your caregivers are under the influence of narcotics and they're unable to care for their patients properly, and it poses a direct threat to their safety or the health of the patients, that's sort of a business necessity issue, which is going to take them outside the protections of the ADA. Yeah, I think that's a fine thing to put in your employee handbook, and this is just good advice to anybody that has an employee handbook. The key is they're good to have, but if you have them, you must follow the regulations in there. Because, for instance, if you have a favorite employee where you're going to let them slide, or if you have an employee that you don't like as much and you're going to enforce it, that's going to be held against you in litigation.
Okay. Thank you.
When they refer to the opioid crisis, is it primarily a problem with prescription medication, or is it a problem with a heroin or fentanyl, or is it a problem with obtaining fentanyl from China, like you mentioned?
The answer is yes. And not to be funny about it, I mean, the answer is all the above. 75% of heroin users started, their first opioid that was down that path was not heroin. It was a prescription medication. Again, maybe not prescribed for them. Maybe they were at one of these Skittle parties, or maybe they were, you know, something like that. But the pathway for a number of those folks was a prescription medication that may have been started off prescribed as a legitimate prescription, or it was obtained illegally. And in my mind, I mean, that's almost the same thing as getting heroin or fentanyl off the streets, right? If you're getting it, something that's not prescribed for you.
But I mean, does there come a point in time where the medical system says to a patient, you don't need 90 Percocets, and then the person says, I can't live without these things? Then do they go to China, or do they go to the streets or to the bars, or
Yeah.
what do they do?
So it's a huge issue that we are very concerned about, and we spend a lot of time talking about this because, as I said, our initial kind of knee-jerk reaction was, how do we turn the faucet off, right, to the pills? Kind of like, if you can just stop the supply, you're going to be good, right? And that's just clearly not it. I mean, that's what happens is folks then they get driven to those areas. The death rates are not going down because we're stopping that. And there's other opportunities for them to get it. And so that's why we really started looking, at least from our perspective at UH, of having more of a holistic approach. So what we do right now, actually, interestingly, is we're starting to pilot a program where if we say, for whatever reason, we need to kind of intervene on your prescription drug use, right? For whatever reason, there could be a number of different reasons. But we're going to get a panel to help us figure out what the best way to get you care for, and that's a psychiatrist, a primary care physician, a pain medicine specialist, and we're going to all consult on the case to try to help get you, because we don't want you winding up on the street and getting to that point, because it's a real challenging, difficult area. But if you look at the global kind of what the problem is, they're all a problem right now, and they're across the board. But prescription drugs. Prescription drugs are a significant gateway.
And you could buy the prescription drugs on the street. So I know of a COO of a major company in Cleveland who started off in college with a sports injury. He's a baseball player. And 25 years later, he's a very successful businessman with a family, was up to 70 Oxycontin a day. And he would have gone to heroin because heroin is now cheaper, but he could afford going down to East 55th and Broadway and going under a bridge and buying Oxycontin on the street. So
the stigma of putting a needle in your arm, everybody says they're not going to do it, right? But if you're not the wealthy guy who can do that, pretty soon heroin is cheap enough and that needle doesn't look so bad. And many people just can't keep up that kind of a habit.
Barbara, you had a question?
Yeah. The pill drop-off centers, how do they dispose of those pills? What is that process?
Here in Lake County, the Lake County Sheriff's Office is responsible for that. They routinely pick up, empty those drop boxes. They dispose of them in an undisclosed location, understandably. So they're able to dispose of them, to incinerate them, essentially. One of the things that we are doing, though, is we recognize, particularly for senior citizens, telling them to put all their prescriptions into their purse and drive to the police department and walk in with those may have some safety issues. So we've been there are these bags called Detura bags that are available. You can put your drugs into the bag, you put water into it, and it deactivates the drugs. So we've started distributing those at senior centers to make it a little bit easier for our seniors to properly dispose of their medications.
And some of the national pharmacy chains I know are starting to pilot where it's just a small little packet. It looks like the little mustard packet you get from, with your food. And it's a powder, and you put it in the pill bottle, and you put a little bit of water in it, close it, and you shake it. It's in the pill bottle, right? So you don't even have to, and you shake it, and it just turns it all into a polymer that you can't get out of it. And some of the pharmacy chains are starting to pilot this where that's being given out with the prescriptions, or you can request that, which makes it, again, you don't have to drive to a drop box, one more step in doing it, potentially getting robbed or whatever.
Then what do you do with that?
At that point, then it's safe to go in the trash at that point.
For the environment?
Yeah. I actually met the chemist who actually came up with it, and it was really fascinating. And they had to go through all these EPA studies and things I don't really necessarily understand. But apparently, the minnows that they put it in the water with for 2 hours all lived. And so that was okay, I guess. That's what I got out of the conversation with them. But yeah, you can put it in your trash at that point, and they can't extract it out of it. So there's becoming more and more opportunities to make it less and less of a burden and hurdle. But I would, ask the pharmacists. Some of the pharmacies are apparently giving it out regularly, and some of them just have it available too.
But the greatest challenge to that is all of us saying, oh, it's okay, my kids would never go in my medicine cabinet.
That's right.
Or I might need that someday.
Or I might need that
Spend a lot of money on that. I'm not going to.
Yeah.
And it might not be your kids, right? It's your kid's friend who come over and say,
Exactly.
hey, Mr. Jernasik, I'm going to go use the bathroom, right? And
Exactly.
what's in the cabinet there? And so that's how those things get out.
Question over here?
Doctor, do you anticipate any of the physicians at UH prescribing medical marijuana? And then secondly, Karen, if you have put anything regarding medical marijuana in the drug-free workplace policies, how you've added that?
You want, I'll let you go first? Or you want
Sure, we're doing a big circuit right now across the state talking about this issue. There are several things I think are really important with employers right now, and that is, in a nutshell, the law is established in Ohio that employers need to make a decision, and you have a decision to make before September 8th when it goes into effect about how you want to address this issue. There is information that says that you're not required to make exceptions to your drug-free workplace policy. You're not required to accommodate, but it doesn't prohibit you from doing so unless you're regulated by an authority who says you can't. So I think step one is to really go through a very regimented decision-making process about how you're going to handle that. And the decision-making team needs to be you, HR, safety, your attorney, really looking at what your decision is going to be based on, and then it does need to go into your policy. If you are not going to let any exceptions to medical marijuana occur, doing that's going to be pretty easy in your policy. You just need to reiterate that. If you are going to make some exceptions, particularly when you look at the operations around that, and I can talk to you afterwards if you want to talk more, you're going to have to do some work. Because operationally, if you're going to choose to make exceptions, you've got to really think through a lot of things. And just to be very, very clear, and I promise it's the last thing I'll say because I could go on forever, but what's really important is that it's not a prescription. It's not a prescription. It's not a prescription. If it were, it would be much easier for employers to handle. It's a recommendation. And because of that, it puts it in a whole different category. I can't treat it like another prescription because it's not one.
And that's law in Ohio. It is a recommendation, not a prescription. That's important to note.
So that for employers, that's huge. And
Working Partners has a great video. I know Dee did a video last year on medical marijuana, but they have done a tremendous amount of work and hours and hours and hours, and I'm really I consider a statewide expert in this area. So.
I'll tell you, from our perspective, the levels of complication just go way up in the healthcare world, and we're struggling with this at UH as well as many other the healthcare systems in the country are in the state. I mean, think of the complications here, right? So I tell you, you get admitted to the hospital, bring all your medications, right? You bring your diabetic med. Now you show up and you're in one of our hospital rooms with marijuana. I mean, there's some challenges from that perspective. You know, over 2/3 of our funding via billing Medicare, Medicaid, right, comes from federal monies. You know, that's a challenge. I mean, it's still not a federal law that you can get marijuana, right? And you know, when you look at a organization like UH, over $4 billion organization, and over 2/3 of our income comes from federal billing, I'm not sure, you know, we got to be really careful where we're going with that. And so there's a lot of other layers for healthcare in addition to the issues that I think you mentioned there, and part of being an employer that we are really trying to weigh, and we don't have a good answer for this at the moment. This is going to really be challenging for us.
I think we could go on and on with questions, but we already are over time. Thank you for your time, and I'd ask that you thank our stellar panel. These are statewide experts. They've given up their time. And I hope we all learned a lot. Thank you so very much. Thank you, panel.